I will hand it over to our moderator, Dr. Richard Fry, in just a minute, but just want to give you a quick reminder. So this is our autism seminar. The goals of these seminars is to take a common bread and butter topic in pediatrics and have presentations from a number of different perspectives. So we've got several different subspecialties represented during this seminar, and we'll have some 30-minute presentations, then we'll have 30 minutes at the end for a Q&A. So please do, as we've said all week, please send your questions in during the talk, and then we'll have plenty of time at the end for our panelists to address the questions. All right, so Dr. Richard Fry will be our moderator. Dr. Fry is a child neurologist here at Phoenix Children's. He is the chief of neurodevelopmental disorders at the Barrow Neurological Institute at Phoenix Children's Hospital. He has a specific expertise in autism and has conducted several clinical trials demonstrating the efficacy of safe and novel treatments that target underlying physiologic abnormalities in children with autism. Dr. Fry, take it away.
Thanks so much. I really appreciate that kind introduction, and I appreciate everybody attending this really, what I think is going to be a very important and informative session. As people probably know, autism is really gaining a lot of attention, and it's really impressive that as we've really monitored it over the past 20 years, we continue to see the prevalence increase, whereas almost 1 in 50 children can now be diagnosed with autism. So it's very important. It's also very multidimensional and really cuts across multiple specialties. And we're just lucky at Phoenix Children's Hospital to have these specialists here that have the interest in autism to really help children and work together. And I think you'll be enlightened by the series of talks that you're going to hear. So without further ado, I'm going to introduce Dr. Mark Ruggiero, who is currently the Chief of Developmental Medicine here at Phoenix Children's Hospital. He's board certified in developmental and behavioral pediatrics and specializes in the evaluation and treatment of teens, children, young adults, and other families with a wide spectrum of neurodevelopmentally based health and wellness challenges, including motor disabilities, autism spectrum disorder, ADHD, learning and mood disorders. He graduated from the University of Florida for his medical degree and did his general pediatrics at Children's Hospital of Oakland and subspecialty training at the University of North Carolina. After residency, he was the director of the multidisciplinary neurodevelopmental clinic and residency training program of developmental pediatrics at Dorbeckers Children's Hospital in Oakland, in Portland, Oregon. And now he's here. So I will let him take it away and start the series up.
Okay, thanks, Rich, for that really nice introduction. And I'm really happy to be here to talk about screening, assessment, and treatment of autism. It's kind of a broad subject, as you might imagine, so I'll go as quickly as I can and cover as much as I can. There will be some things on the slides that I won't be commenting on directly, but you'll have them to refer to. I will hand off to Dr. Todd Levine halfway through the talk to talk more about treatment. So autism, as you know, is a neurodevelopmental disorder with core deficits in 2 domains now in the DSM-5. So there's social communication and restrictive repetitive patterns of behavior and interest. The prevalence, as Dr. Fry had indicated, is definitely gone up, and you can see it's tripled from 2004, where it was 1 in 166, and now we have about 1 in 50, 1 in 60. And it's probably multifactorial as far as the reason for the increase. We have awareness that's gone up. Obviously, we have the universal screening that's happened over about the past 15 years. And the broadening criteria of the DSM-5 has had some impact. We have increase in school-based services. We have some diagnostic substitution, where kids in the past that were diagnosed with intellectual disability now are being diagnosed with autism with intellectual disability. But there's probably a true increase due to biological factors, and I think Dr. Nielsen and Dr. Fry will address those a little bit later. So It affects about 5 million people in the United States, and over time, there's been a reduced racial disparity in prevalence, and probably because of increased awareness, and the gender difference is pretty significant. You can see that boys to girls, about a 4-to-1 ratio. The standard screening, as you know, is between 18 and 24 months, and they can be diagnosed as young as 18 months at this point. Fortunately, the average diagnosis is at about 4 years, and also, unfortunately, about less than half are evaluated by 3 years of age, and I'll talk a little bit more about that. The cost is significant, and it ranges from 1 to 3 million for an individual, but it's true that early intervention and therefore screening definitely alter the trajectory of the biological and behavioral development. I'll talk a little bit more about that. The DSM-4 was 3 core symptoms and 3 domains, and you can see that the social reciprocity and the communication, the restrictive and repetitive behaviors were there. There was a broad umbrella term of pervasive developmental disorder, which caused some confusion, and those are the diagnoses that were underneath that broad umbrella, including childhood disintegrative disorder and Rett's disorder. There was overlap, significant overlap between autism, Asperger's, and PDD-NOS, and there was inconsistency in how those diagnoses were made. And so they decided to consolidate the subgroups into one large ASD group. And the increase in prevalence is maybe contributed by that consolidation, as studies would show that almost all of the old Asperger's and about 80% of the PDD-NOS patients would be diagnosed with the new autism through the DSM-5. The DSM-5 took out the communication subgroup. So you have 2 now, and it's basically social communication, social interaction. You need all 3 of these. You can see the reciprocity and the nonverbal communication and developing relationships, and the restricted repetitive behaviors and patterns of interest include the repetitive motor movements and use of objects, the insistence on the sameness, routines, cognitive rigidity, and then highly structured and intense interest. And also they added in the DSM-5 the hyper and hyporeactivity to sensory input, which again is not specific for autism, but is often seen with autism. So it was added as a criteria. This is just a table that I added to give you an idea, and it's in the pediatric publication that I'm referencing. And it gives you some examples of each one of the deficits so that you can kind of look to see what some of those examples are. The DSM-5 definitely identifies younger children with milder symptoms. The severity rating has been added, and the level 1, 2, and 3 indicate the increasing amount of support that a child would need. And also it's an important point to look at the functional limitations and the functional impairment as you go up in levels. They don't give us anything quantitative to use to determine these levels, but it would be a judgment call by the diagnosing provider. There's also course specifiers, and as I mentioned earlier, you would add with or without intellectual disability, language impairment, and so on. The other disorder that was added in the DSM-5 is social communication disorder, and it's really meant for the patients that have the social communication deficits, but not enough of the repetitive behaviors and patterns of interest. So early detection screening is so important. We know that it improves the long-term outcome. One of the theories about the neurobiological problems and causes include dysfunction related to overgrowth of connections in the frontal lobes early in the postnatal period in children with ASD. These abnormal synaptic pruning leads to damaged neurons and an abnormal or increased network of defective connections. So without the pruning, you have an abnormal connectivity within the brain. The environmental effect of the interventions adjust and change the construction of the neuronal circuits and eliminates these excess synapses and connections. So early intervention, early as possible, will optimize outcome before the neuronal circuits have been formed, and it requires fewer services later. So screening, AAP, as you know, recommends autism-specific screening at 18 and 24 months, and it complements a general screen. Screening lowers the age of diagnosis and treatment, which we're all really trying to to get to. MChat RF, it's the modified, and it is the 16 to 30 months valid for screening. And overall, the rates have increased in primary care. Over time, we've seen an increase in the use of these. And now, based on different surveys, about 50 to 75% of primary care providers are using them regularly. The sensitivity of surveillance versus screen is pretty significant. And if you look at 0.24 for surveillance and 0.91 for screening, show how important the MChat is. So as you probably know, the score 8 or higher indicates high risk and just refer, and 3 to 7 is medium, and so there's an interview. A lot of primary care people are not really, they might know about the interview, but they're not really familiar with the questions. If you look at mchat.com, mchatscreen.com, you'll get the algorithms for each of the interview questions. And if after the interview for the positives, there's still 3 to 7, then there's about a 40 to 50% risk of having a diagnosis of ASD. That can vary depending on the person, but what's really interesting is that 95% chance of these kids having a developmental delay. So it's almost like an additional developmental screener. So under additional tools for under those ages are under investigation. So we're really looking forward to having more tools at younger ages and older ages for that matter. So this is an example of the MChat on the left and then the follow-up scoring on the right. The only difference is yes, no versus pass and fail. And I wanted to show you just 2 algorithms for when you get a positive, and you just go to those 3 to 7, however many there are. And on the left, I'll just go through that quickly. If you get used to these, they go much faster. And I think each one would only require a few minutes, maybe 2 to 5 minutes, depending on the parent. So for example, does your child try to copy what you do? So this is asking about imitation. Yes, you don't have to do anything. No, if it's a no, then you go through that list of questions, yes and no questions, as your child stick out your tongue and so on. And you can see that if there's yes to 2 or more, then it's a pass. If there's yes only to 1 or none, then it's a fail. So I think if you familiarize yourselves with these over time, it'll be much faster, and it definitely increases the sensitivity and specificity of the MChat. Barriers or unfamiliarities I mentioned before. I think in this particular study, about 58% of the primary care providers said that they're unfamiliar, and 44 said that they didn't have enough training. And I remember when the follow-up questions came out with the MChat, there were a lot of people that just didn't get training on that. But I think that that's something we have to overcome. Definitely time constraints, insufficient reimbursement, and then limited understanding of the referral options. I think we all want to have a partnership, and we want to help with those referral streams in terms of how to get the referral from you to us and for other developmental centers and where other community partners are. So unfortunately, the primary care pediatricians are tasked with identifying all children with developmental delays for the most part. And just to show that, the Pierce and his group looked at a network of providers, and they gave support on screening 12 months olds. And the infant toddler checklist was used, and it's used to identify communication delay and autism spectrum in 6 to 24-month-old toddlers. And they also were given informational referral guidelines, and the results showed that the children later diagnosed with autism were identified and diagnosed and began treatment at about 20 months. And if you compare that to the 4-year-old average, I think that's pretty significant. And it shows the impact of the screening and also having that collaborative input and relationship. So in the primary care setting, primary screening is limited because unfortunately there's no current recommendations for the AAP for children greater than 30 months. And that's one of the things that I had talked to Dr. Fry about. And there's definitely some more work needing to be done and some more tools for you guys to use. We use 2 that are not free, and they are copyrighted. The social communication questionnaire is validated for 4 years and up, and then the social responsiveness scale is validated for 30 months to 18 years. We use both of those as screeners for the older kids. But due to the absence of these screening tools, often children with milder symptoms and average IQs may not be identified until school age, and we're getting a lot of those referrals now. Sometimes the social language problems and the rigidities just don't affect functioning until they're older. Also, coexisting conditions like ADHD can prevent the clinicians from recognizing symptoms. And with ADHD diagnosis and autism, the children are diagnosed about 3 years later than with no ADHD, as an example. So secondary screens are really important, and we're doing those within our algorithm and protocols. So they increase the predictive value and they conserve resources. And we're using two. I just wanted to let you know about the STAT and the RITA. The STAT is the screening tool for autism in toddlers. And you can see that it only takes about 20 to 30 minutes. And the rapid interactive screening test takes about 10 minutes. And we're using those in the younger kids. Unfortunately, as you can see again, after 3, we don't have objective measures to do screens, and hopefully we'll be able to get more of those. So you all probably know about the ADOS as kind of like the gold standard, and we do use those on some kids. We don't have to use those on all, and it can be very helpful, especially in cases where they're high functioning and the parent report is inconsistent with what we're seeing during the evaluation. The ADIR is a very long interview, about 2 hours, and it really structures the parent in terms of what their report is, but it's still based on the parent report. And the CARS too has the high functioning and the younger kids, and it's a 15-point scale that includes the parent report and your observation. So it's subjective and objective, and it's a really good tool in terms of screening, but also as a evaluative measure. The medical workup is, as you know, you're looking for anything that might be an underlying medical cause. And I think these are the things that you would be looking for. Of course, exposure, dysmorphology, neuroimaging is usually not ordered unless there's something in the history of the physical exam that would indicate that, especially micro and macrocephaly. And EEGs are not recommended unless they have symptoms. And I'll not talk about the genetics and epigenetics because we have Dr. Nielsen, but I'll just mention quickly that biomarkers are being looked at to help with identifying kids earlier. Genetic, biochemical findings in the blood, urine, or wherever. And hopefully in the future, we'll have some biomarkers that will help you and us indicate the kids that are at risk earlier on. The basic recommendations for CMA and Fragile X are there. And again, Dr. Nielsen will talk about that. And metabolic screening usually isn't done unless there's a history or physical findings that are significant for the things mentioned here. The treatment, I'll talk about just the behavioral treatment, and Dr. Levine will talk more about medication. But the goals for behavioral treatment are to minimize core deficit. So you're really looking at minimizing the social communication issues and the repetitive behaviors and interests. You're maximizing functional independence, and you're minimizing problem behaviors. And Dr. Levine will talk more about that. You're trying to maximize the educational interventions, obviously, because the child's spending so much time in the school. So you have to help them with the IEP and make sure that they're getting what they need. And, sometimes they'll have a designation for autism on their IEP, and sometimes they won't. Sometimes they even have to get advocacy. So you do want to ask them about the IEP. We always ask for a copy of it, and we go over that with the parents. Developmental therapies include floor time, and behavioral interventions include ABA, and I'll talk a little bit more, and some combined approaches. The ABA is really important, and it's still really it goes far back, and it's still the most evidence-based intervention. And it's really meant to alter these behaviors and increase skills by reinforcing these new skills. So there's positive reinforcement plan that's very structured, and it can also minimize behaviors that can interfere with progress. There's a board-certified behavioral analyst that determines these goals, and it can vary from highly structured to child-led natural environment. It has the most evidence support, and it's much more likely that these kids are going to achieve goals if they're getting ABA. The other two, the developmental models, are floor time and Stanley Greenspan really has identified a really nice way for parents to coach their own children on social responsiveness and social play. And naturalistic development is another developmental model. The TEACH model is really great for school, and it's very structured based on visual schedules and organization, and the benefits are significant: perceptual, verbal, cognitive, and so on. The other therapies are really good. The PEC system is for communication, it's a picture board, and then of course treat the co-occurring conditions. And thank you very much. I'll go ahead and hand it over to Dr. Levine at this point to talk more about treatment.
Thanks so much, Dr. Ruggiero. Next, we have Dr. Levine. We're very lucky to have him come from Brown University, where I believe he finished his child psychiatry fellowship. He specializes in psychiatric issues in children and adults with autism spectrum disorder, and provides treatments including medication management, family therapy, individual therapy, and school consultation. So with that, we will listen to Dr. Levine.
Thank you so much, Dr. Fry. It's a pleasure to be here. I arrived 6 months ago, and I have found a very collaborative effort, as is demonstrated here, on trying to really harness and bring in a holistic approach to autism treatment. I know that we as specialists are overwhelmed with the avalanche of people coming in for referrals, and of course understand that we're relying very heavily on people in the community to make these efforts and make these diagnostic assessments too. So what I wanted to do was focus, as Dr. Ruggiero was talking about, with talking about basically what I see a major issue going into these situations is behavior. So most of the patients that I see are diagnosed with autism and have major behavior issues like attention and anxiety and things. And I'll just speak from what I've sort of understood and done. So basically, we know when we encounter someone on the spectrum, we're dealing with a very different type of patient than a non-autistic patient. And so meaning inherently in someone on the spectrum, we have difficulties with language and communication and socialization. So our sort of assessment of the individual needs of that particular person are limited. And of course, we're relying on a tremendous amount of work and collateral information from the families in order to make those kind of assessments. So even if we have somebody who's nonverbal and has a lot of self-stims, that's a difficult assessment to make in terms of understanding behavior and motivations. And of course, even in the Asperger patients that I see, who are incredibly fluent and very articulate, still have difficulty expressing their internal motivations and moods. And so we wind up in a very difficult diagnostic kind of predicament. And so, of course, I know, having done the pediatric training in the past, I know that behavior is a paramount issue facing pediatricians, particularly in autism. So I sort of break down the autism kind of behavioral parts, not into diagnoses, because I think that our diagnostic manual is effective, but is not necessarily embodies all the things we see in autism. So I think about 4 major categories. The first one is sleep, right? We know that children with autism generally have many types of sleep disturbances. So I think sleep. There we go. So sleep is the first one I mentioned. We could advance to the next one. Anxiety and mood, which I had mentioned. We'll go into these more specifically. And then the third category we talked about is irritability and aggression. And finally, the fourth category would be attention and hyperactivity. So if we advance to the next slide. So insomnia is a commonly seen in children. I break it into 3 different categories. I have initial insomnia, meaning trouble falling asleep, and I consider initial insomnia to be an hour or more of sleep latency. Terminal insomnia, which I would say is waking up an hour or more earlier than we'd expect based on natural sleep cycles, as well as frequent waking. We always have, it could be any 3 of those or one of them individually. For initial insomnia, I use melatonin, good old-fashioned melatonin. The dose ranges can be as low as 0.75 milligrams to 10. Many studies are in the 3 to 6 milligram range. I usually have patients start with 1 to 2 milligrams to start with. bump up in 1 to 2 milligram intervals with kind of a max being 10. I haven't found more than 10 milligrams to be terribly effective. So we're talking about kids that are taking an hour or two to fall asleep. And of course, you guys in the pediatric community have always been already talked about. These are families that are prepped on sleep hygiene issues and have worked through a bunch of behavioral strategies. Melatonin can work very well. Extended release can be helpful for terminal insomnia, but the one that I use most often, which is a trick I learned from my autism specialty kind of colleagues at Brown, was mirtazapine, which is an old school antidepressant which has histaminergic as well as serotonergic effects. And a standard adult dose is like 15 to 30 milligrams. I start at much lower doses, like 3.75 milligrams, and I sort of work my way up. Mirtazapine is for the kid who is is waking up at 2, 3 in the morning and not falling back asleep. It can be used, so if you have someone who's got a combo effect, meaning initial, terminal, as well as frequent wakings, it can do all three of those categories as well too. So it's a less prescribed antidepressant and has really become a sleep aid for many of us working in developmental disabilities. If we go to the next slide, that'd be great. So anxiety is near and dear to me in the sense that I think anxiety has a lot of underlying issues related to all sorts of externalized behaviors, including aggression, irritability, and frustration. So the way that I think about it is we have generalized anxiety, which are kids who are constantly worried about everything. It's the worried wart kind of mentality. That's someone who, it's sort of like an octopus that sort of grabs onto whatever's around it, meaning that they're always feeling anxious and they could be asking, do we have gas in the car? Is my homework going to be ready? Are we having a major sandstorm? Those types of things. Where I was from in Rhode Island, it was a hurricane, but here it's different weather fears and stuff too. Social anxiety is a fear of social evaluation. Social avoidance, as a natural part of autism, doesn't necessarily have to be due to evaluative worries from other people, but it's a very true, for those that have it, it's very strong, meaning avoidance of people because of worries that what others will think of them. And then obsessive compulsive disorder, which is, anxious, ritualistic, and intrusive worries that lead to compulsions, which are ritualistic acts to counter that. The issue that we have in autism is that oftentimes these children and young adults come in with restricted interests that seem obsessive in the sense that they constantly think about certain statistics from sports teams. They're really into Pokemon. They're really into whatever they're into, and they can speak incredibly deep and incredibly almost in pedantic ways with people. That's a different thing for me. That is an autism specific thing. Obsessive compulsion for me means that there is a dysphoric worry associated with a ritualistic act, but they can come together in certain ways. So distinguishing that can be incredibly difficult to do. I'm going to advance to the next slide. So if we're in those three categories of anxiety, whether it be generalized, social, or obsessive, SSRIs can be incredibly effective. I'm a big fan of sertraline, but when I explain to families, and when I learned it where I was training as well as here, everyone has their favorite SSRIs. I just use sertraline, but anyone is effective. I tell the families when we're starting one, I could easily make an argument for Prozac or Lexapro or citalopram. But I found, I started doing this because there was a great, robust data from the OCD literature using SSRIs, and I find that they just had success with it. I always start at 12.5 to 25. Usually I would say 12.5 for anyone 10 and under, and then maybe 25 for those starting. And I'll go up in 12.5 to 25 milligram intervals. And I find it to be incredibly successful for a lot of the perceptive anxieties in kids on the spectrum, particularly those, there's one particular type of anxiety that I see often, which is a perceptive worry about scheduling and sameness, right? This can be incredibly effective for that. And then the side effects are generally, when I tell the parents, I usually say, it's rare that I see many of these, but the most common ones would be GI upset, tremors, and I also see some just transient diarrhea oftentimes. The suicidal thought component, when I was in training, that was an incredibly big deal. But I think psychiatry probably made a big mistake by really emphasizing suicidal thoughts and behaviors. That was based on I think a statistically significant adolescent finding in depression that unfortunately set us back in terms of utilization of SSRIs. But I think we've recovered from that. So suicidality and things I don't find to be a tremendous part of this. So we can move forward. Next slide. So irritability and aggression is thankfully an externalizing behavior that is always there. We're talking about, you know, tantrums, hitting, spitting, biting, things that you can see, things that are incredibly stressful for a family. The thing about it is utilization of psychiatric meds for these types of behaviors usually need to be high end. Like, I don't use risperidone on a kid who had a tantrum last week and has been fine for 3 weeks from there and is good for an explosion every so often. I'm talking about kids that are constantly on edge and at risk for a self-injurious, aggressive, or disruptive act. And if we advance to the next slide, please. So risperidone is the one that got FDA approval back in 2004, and for good reason. And this graph here really demonstrates what happened, right? And so the reason I show this is because this mean irritability score is based on a rating scale called the Aberrant Behavior Checklist. And you can see the placebo effect obviously had some effect, but statistically significant was this decrease with risperidone. This 25 does not represent, like I said, represents an incredibly disruptive, aggressive, irritable child, right? But you can see it, and it still goes down to about half. This place still is disruptive, but better than here, right? So I usually reserve antipsychotics for people that are consistently showing a disruptive, pervasive process going on. And I think this is actually quite a good graph that illustrates that as well. And you can advance to the next slide, please. So for ADHD, I find this to be one of the most difficult areas in terms of medication effectiveness, because this is one of those situations where I would never say always, but I would say almost always, if a child comes before me on the spectrum and has any sort of neuropsych testing, they're going to have executive functioning issues, short-term kind of processing issues, as well as attention issues, right? It's the most common pathway, but also these symptoms are also the final common pathway for kids that have anxiety, for kids that have depression. So I find myself particularly I think it's one of the harder places to wrap our minds around in terms of success. And the data also says that kids with autism, ADHD symptoms generally respond less rigorously to the meds and also have more side effects. So I put guanfacine, not that it's a first line choice, but I think it is less likely to induce some of the activation and paradoxical effect of some of the stimulants. So I find it to be very good for the hyperactive, impulsive child. Traditionally, I don't find guanfacine to be helpful for attention per se, but if you can slow down a lot of when I see a very physically impulsive, hyperactive child, I'll often go to guanfacine as a first line choice. And, it can be done as Intuitive, which is a long acting, and, the dose is 1 to 3. I usually start at 0.5 milligram once or twice a day and sort of work way up from there too. And with guanfacine, sedation and constipation for me are the most common side effects. If we could advance to the next slide, please. So methylphenidate, whether you're methylphenidate or amphetamine salts, the stimulant medications for ADHD, there have been surprisingly few Adderall or amphetamine salt trials out there. So this is based on an article from 2007. And unfortunately, we haven't had much more robust, there's been a sort of a lull in the autism psychopharmacology arena. But what they showed was that only 50% of children on the spectrum with hyperactivity showed a response to methylphenidate, whereas 75% of controls did. And the improvements were also less robust, meaning there were 20 to 25% improvement in those kids on the spectrum that responded versus 50% without the autism, meaning that you're less likely to get the benefits, and even those that get benefits are less robust. And a higher dropout rate due to some of the traditional, I think, ADHD or stimulant med effects, irritability, aggression, and insomnia. I see, obviously we see appetite suppression as well. I haven't seen any cardiac effects usually, and I only screen with EKGs for those kids that have a strong family history of cardiac issues. So between methylphenidate, or if you have amphetamine salts are fine, and the alpha-2 agonist a la guanfacine, you could also make choices in long-acting clonidine, although clonidine tends to be short-acting and I don't think it has a great effect over time. And so you can advance to the next slide, please. So when I think about the difficulties in understanding how, and like I said, I'm not a psychotropic med like emphasis, but certainly I know how effective these tools can be if applied in the right circumstance. And I know in a pediatric setting, a well-placed medication intervention can make a world of difference in terms of how we treat these kids. And so usually when I see these kids, they've already been tried by very valiant efforts and actually very good, healthy prescribing by people in the community. And what I'm really doing is kind of maximizing or tweaking or doing different things too. But so I took just a bunch of symptoms that from the data at the point, I must have done this about 5 or 10 years ago. Here's what we're treating with psychiatric meds. We talked about all of these. And if we advance to the next slide, we also have the side effects of psychiatric medications, which look very similar to the things we're trying to treat as well too. So if you go back to the previous slide for a moment, you can then go back one more, go forward again. Oh, I'm sorry, forward. One more. Yeah. So the reason I'm saying this is that what we're treating and what we're inducing by potential side effects are not that different. So one of the major challenges that I find is when we're starting a psychiatric medication, are we effective? You know, and what I tell the families are, we have the benefits, the potential benefits and side effects, and with each titration, we're trying to balance those things. So sometimes when I'm trying risperidone and it's not working out well at doses I'd wanted to, am I not treating the behaviors effectively, or am I inducing a side effect like akathisia or agitation and things like that too? So the art of the figuring out of this can be incredibly stressful and difficult. And I think that's where the subspecialty care comes in, right? That's where I think the referral to us to manage those things is where it comes in. So but I'm just doing that as a respectful process to anyone who's prescribing psychiatric meds. Are we under-treating? Are we over-treating, meaning too high side effects, or are we causing something problematic? If we could advance to the next slide, please. So when it comes to medication prescribing, the meds can be useful for specific targeted behaviors with those on the spectrum. It's not about, I don't diagnose anyone with, it's about symptom resolution as opposed to diagnostic DSM clarity with treatment, I think. And then kids on the spectrum can always be more sensitive to side effects, so I always start low and go slow. And then I think the basic initiation of psychopharmacology in the primary care office is very possible and really necessary too. So I know if we brought in 10 psychiatrists to do autism, their rosters would be full, later, it would take longer to fill their space, but it would happen, right? So we have a tremendous dependence and there's a tremendous amount of behavioral health necessity placed on primary care offices. And we need more research in the area. So as we develop, I'm new, and we're all actually relatively new between Dr. Ruggiero and Dr. Fry and I over the past few years, we're trying to really create, as Dr. Ruggiero said, a streamlined referral process into us to be available for these complicated cases. And Dr. Fry is already introducing to the community a lot of diagnostic assessment tools and learning modules to do that. And I'm planning on doing a similar thing for psychiatric care. So we really appreciate your presence here and continue your great efforts. And we're hopefully here to answer as many questions and be as available as we can for you.